Hi, everyone. My name is Dr. Don Buford. I'm an orthopedic surgeon and the director of the Texas Orthobiologics Institute. I want to thank the course organizers for the invitation once again to present at the 40th Annual Cherry Blossom Seminar. I'm really excited to bring you some new 2021 data on evidence-based orthobiologics. We're going to separate orthobiologics into two broad categories in the interest of time. We're going to have an allograft orthobiologic category, which we will quickly dismiss, and then we will have the bulk of our time spent on platelet-rich plasma and just a little bit of time on bone marrow concentrate and adipose tissue orthobiologic options. Allograft orthobiologics. Well, we're talking about injectable amniotic fluid, umbilical cord blood, Wharton's jelly, and exosomes. All of these products have significant regulatory, safety, efficacy, and cost issues. Virtually all of these products, save two, are regulated under Section 361 of the FDA. This means that they're virtually all misregulated, misbranded biologic drugs. They violate Section 361 criteria, either on minimal manipulation criteria or non-homologous use criteria, or both. The two exceptions, one product called AmnioFix and the other product called Renew, have both received FDA RMAT designations, which now allows those products to be marketed and sold and used and studied in humans for knee arthritis only. None of these allograft injectable products have functional stem cells at the time of delivery, despite incredible marketing campaigns to convince us otherwise. There are essentially no published orthopedic controlled trials for any of these products in humans for any orthopedic diagnosis. This is the allograft orthobiologics wall of shame. Every company on this slide has received some flavor of FDA communication informing them that they are in violation of the FDA regulations. Let's talk about PRP. Now, this is an autograft orthobiologic. This is an orthobiologic that has mounting evidence for many, many different orthopedic indications. Probably the most common place where PRP is used right now is in knee arthropathy. In 2020, there was a level 1 meta-analysis published, and this meta-analysis looked at 30 separate independent level 1 studies to come up with the conclusion that PRP was better than steroid, better than hyaluronic acid, and for sure better than placebo at every time interval they looked at. They looked at patients 3 months after injection, 6 months after injection, and 1 year. PRP was better than steroid and hyaluronic acid at all three of those time intervals. 2021 has already been a good year because there's been a level 1 study published showing that PRP is better than hyaluronic acid for patients that have hip arthritis. In this level 1 study, 34 patients were evaluated. At the 2-year follow-up mark, 50% of the patients that had hyaluronic acid injections had progressed to total hip arthroplasty. However, only 15% of the patients that had PRP injections progressed to hip arthroplasty. And this difference, 50% versus 15%, was statistically significant. The authors concluded that LP-PRP delayed the need for surgery in these patients with hip arthritis. The medial collateral ligament is another area where PRP may be an effective treatment. In these patients who were all symptomatic for 3 months before treatment, these patients had 3 injections of PRP separated by 1 week. And what the authors found was that patients' pain started to improve by 1 month, and by the 6-month follow-up interval, these patients had all recovered and the MCLs had all virtually healed. Ankle arthritis and ankle sprains are 2 more lower extremity diagnoses where PRP has recently been shown to be effective. For patients with ankle arthritis, a level 2 study published in 2020 showed that a single 3 cc injection of PRP could lead to greater than 50% pain reduction by 6 months. This was a level 2 study. In 2020 also, another level 2 study looked at patients that had grade 3 ATFL ligament injuries. What this study found was that PRP led to significant reductions in pain and improvement in function starting at 1 month, and that this improvement was durable out to 1 year. Rotator cuff tendinopathy has been studied. In 2020, a study was published that looked at 128 patients. These patients all received ultrasound-guided subacromial PRP injections. At the 3-month follow-up mark, 70% of the patients had significant reductions in pain and improvements in function. The primary predictors of failure in this study, type 3 acromions and AC joint arthrosis. A level 1 study was published this year by Ian Lowe and his colleagues. This was published in the Journal of Arthroscopy. They looked at just under 100 patients, and they compared PRP injections with subacromial steroid injections. And what they found was that the platelet-rich plasma injected group did better at the 3-month time interval. However, if you look at 1-year results, the results were essentially equivalent when comparing PRP to corticosteroid. Elbow tendinopathy has been a well-established, maybe one of the most well-established uses for PRP in orthopedics. In 2013, Alan Mishra and his colleagues published their landmark level 2 study looking at 230 elbows. One group got dry needling alone. The other group got dry needling plus PRP for lateral tendinopathy. At the 6-month mark, the dry needling group had a 68% success rate in ameliorating their symptoms. The dry needling plus PRP group had an 84% success rate. And this difference, again, was statistically significant. Alan's results have been confirmed over the years multiple times. There was another study published in AJSM in 2019 in which the authors concluded that the use of PRP does yield statistically and clinically better improvement in long-term pain compared to corticosteroid for lateral epicondylitis. The elbow ulnar collateral ligament is a structure that, as sports medicine doctors, we see increasingly injured, especially in a younger and younger patient population. It is very difficult to recommend surgery on a 14-year-old elbow for this problem, and we are all looking for ways to avoid surgery and yet return the patient to function and ideally have this injury heal. Well, PRP may be a path towards answering that clinical dilemma. There was a nice level 3 study published in 2021. 50 elbows were evaluated, and from a single PRP injection, 64% of these throwers returned to throwing. One dose of PRP. When you look at the overall results, 72% of these patients returned to throwing, most of them after that single dose. There were 3 additional patients that returned to throwing after a second dose. No one had 3. Carpal tunnel syndrome and trapeziometacarpal arthritis are 2 additional diagnoses where platelet-rich plasma has recently been shown to be effective. There has been a nice level 1 study published in 2021 showing that PRP is more effective than placebo for carpal tunnel syndrome. The study design was very simple. We have patients with bilateral moderate to severe carpal tunnel syndrome. One wrist gets a placebo saline injection. The other wrist gets 3.5 cc's of platelet-rich plasma. The PRP group was better at every single time point out to 1 year. And what about trapeziometacarpal arthritis? Well, this is a level 1 study published in 2018. Patients received 2 injections separated by 2 weeks, and it was compared to corticosteroid. The PRP group was better than the corticosteroid group at every time interval, and this improvement was durable out 1 year. PRP use for SI joint and caudal epidurals has been shown to be very effective. In 2020, there was a level 3 study published looking at 50 patients with SI joint dysfunction. A single injection of ultrasound-guided PRP gave at least a 2-point pain score decrease, and it started at 1 month and was durable out to 1 year. PRP also gave about a 10% functional score improvement, again, starting at about 1 month and carrying out about 1 year. What about the epidural space? In 2020, there was a level 1 study published comparing leukocyte-rich PRP with corticosteroid injections for caudal epidurals. A single injection of leukocyte-rich PRP was judged to be safe, and the clinical outcomes strongly favored the PRP injection over corticosteroid. Lumbar discogenic back pain is yet another diagnosis where PRP has been very effective. In this 2016 level 1 study, Greg Lutz and colleagues injected lumbar discs with a single injection of PRP. The PRP group had significantly better outcomes starting at 2 months, and they were durable out to 1 year. We have 2 other autograft orthobiologics just to touch on briefly. Bone marrow concentrate is being used in increasing numbers in the United States, as is adipose tissue, at least the FDA compliant version of it in this country, which was primarily the microfat or the nanofat versions of adipose tissue. Bone marrow concentrate has studies published over the last 3 years in these particular orthopedic areas: knee arthritis, knee bone marrow lesions, shoulder arthropathy, rotator cuff tendinopathy, and lumbar discogenic back pain. In these areas, the average level of evidence for BMC is 2.3. That's important to me because the average level of evidence in 6 of the top 10 orthopedic journals has been shown to be 3. So at least over the last 3 years, for these specific diagnoses, bone marrow concentrate outcomes are certainly reaching a level of evidence that most of us in the orthopedic world would accept if it was published in any of these 6 journals. The FDA compliant types of adipose that are used in the United States include the Lipogems system and the Tulip system. And for knee arthritis, shoulder arthritis, or cuff tendinopathy and hip arthritis, there have been recently published studies suggesting that adipose can be an effective clinical agent. The average level of evidence is not quite as high as bone marrow concentrate, but it still just about matches the average level of evidence that we accept in our top orthopedic journals. 3.3 is the average level of evidence. So in conclusion, the allograft orthobiologic market just has too many red flags. We have evidence problems, we have potential safety problems, we have an enormous regulatory problem, and we have the cost issue. These products are just more expensive than autograft options that have better evidence. PRP has outstanding clinical evidence for many orthopedic conditions, to the point that PRP should be a frontline, minimally invasive choice before a surgical option is considered. Bone marrow concentrate has less human outcomes data than PRP, but the results are definitely trending towards BMC being a viable option for many of the same orthopedic conditions. FDA compliant adipose tissue has less human outcomes data than BMC even, but in a very similar fashion, the data is strongly trending towards adipose tissue being a strong clinical option for many of the same orthopedic conditions. Thank you very much.